Good morning, everyone. Welcome to the inaugural lecture of the We Care lecture series organized by the Humane Care Expert Committee of Sri Lanka College of Internal Medicine. This lecture series is initiated with the vision of the Humane Care Expert Committee, bringing humaneness to the bedside. Topic today's inaugural lecture is themed as The Person Beyond the Illness, a Humane Approach to Care. We are honored to have an eminent clinician and a specialist in internal medicine with us today as the guest speaker, who has pioneered in bringing humane care to the field of medicine in Sri Lanka. First of all, let me cordially invite Dr. Krishantha Jayasinghe, the President of Sri Lanka College of Internal Medicine, to welcome the gathering. Over to you, sir.
Good morning, ladies and gentlemen. It's with great pleasure and deep respect I welcome you all to the inaugural lecture series organized by the Humane Care Expert Committee of the SLCIM under the inspiring theme of We Care. Through this series, we aim to reflect on how we as internists can uphold humane values in every aspect of clinical practice. It is a particular honor today to welcome our distinguished guest, Professor Saroj Jayasinghe, a physician, academic, and a leader whose contribution to medical humanities and person-centered care have shaped the way we think about healing human. Professor Jayasinghe has consistently guided us to go beyond the biomedical model and consider the broader social, cultural, and emotional context of our patients. This advocacy has laid a foundation in SLCIM for a more humane and holistic approach to healthcare, making him the perfect person to inaugurate this important lecture series. Dear sir, we the Council 2025 are deeply grateful for your presence today and eagerly look forward to your insights, and I would like to extend my gratitude to Dr. Ganaka Senaratne, President SLCIM 2022, for his visionary leadership in this project. To all our physical and virtual attendees, thank you for joining us as we embark on this meaningful journey together. Let us begin We Care. Thank you.
Thank you very much, sir. Now I invite Dr. Ganaka Senaratne, the President of Sri Lanka College of Internal Medicine for 2022 and the Chair of the Humane Care Expert Committee, to introduce this program and our esteemed speaker.
Good morning, everyone. Dr. Saroj Jayasinghe, Emeritus Professor of Medicine, Dr. Krishantha Jayasinghe, President, Sri Lanka College of Internal Medicine, and Dr. Harshatis Chandra, past President, and all the members who have gathered physically and virtually. So it's a very heartiest day for us in SLCIM Expert Committee on Humane Care as we begin our project in this year. So if I let you know about a bit of the history, we established this expert committee in 2022, wasn't it, sir? And then we've been doing a lot of webinars on this aspect and storytelling sessions and discussing about legends on this field, and then moving into annual academic sessions, having a scientific session there. And we went to regional meetings with this topic to discuss these concepts with doctors, nurses, and others. And now we are in 2025. We have met, the Humane Care Expert Committee have met a couple of times, and we have elaborated a few things. We have discussed few things to be done in this year. One thing is going along with the setting standards in clinical medicine as SLCIM. We were able to do a symposium, island-wide symposium for doctors, and it will be followed by nurses as well very soon. And then this is the second project actually we discussed about to have a bi-monthly lecture series by an expert on this field. We termed it as We Care, thinking that these concepts can be popularized. And then we will be trying to develop a publication and couple of research under the guidance of Prof. Jayasinghe and the expert committee. And then hopefully we will be having a pre-congress session on humane care this year as well. So we have lined up several stuff for this year. I'm pretty sure with the enthusiastic membership of the college and the expert committee in humane care, we have 20 members this year, sir. Very enthusiastic, young and senior members. We will be able to mount a good program. So here we are today for this first talk on We Care. I'm really glad to have Professor Jayasinghe, who is an Emeritus Professor of Medicine and the founder, head of the department in Medical Humanities in Faculty of Medicine. More importantly, he has been our mentor and an honorable committee member in this very juvenile expert committee, I would say. So I'm really thankful for you, sir, for accepting our invitation to deliver this talk. May I invite Professor Jayasinghe for his talk today, themed as a patient beyond the illness. Over to you, sir.
First slide, please. Thank you very much, Janaka, and thank you, Krishant, and the college for inviting me. And thank you once again, Ganaka, for inviting me and giving me this honor to make the inaugural lecture in this series on We Care. Now, as we begin this presentation, intellectual debts, one is to Professor Nalaka Mendis, who has been a guiding light in these issues and advising us from the time we embarked on curriculum change. Then my good friend, Professor Panduka Karunanayaka, who is on his sabbatical and who also has been a constant a person who has constantly encouraged, and Professor Dr. Diyanath Samarasinghe, who also brought in these concepts in his own way and has been using some of these concepts in Rajarata. So my topic is a person beyond illness, the person beyond illness, a humane approach. So I begin with this. And physicians they would probably know what this is, the diagnosis. Now, what's useful in this is I'm trying to highlight an issue. For us, it's a patient with Ramsay-Hunt syndrome or a case of Ramsay-Hunt syndrome. But for the person who is ill, it's headache, pain in the ear, fever, and asymmetry. But if you ask a layperson, his description would be completely different. The layperson would describe a middle-aged gentleman who is not shaven, looks quite distressed, and is having an asymmetry in the face with some rash in the ear. And if you ask the patient or this person, he will relate to you how difficult it is, at what sort of stage this illness has affected him. The fact that he has to complete his harvest, he's a farmer, and he needs money quite urgently because there are so many other obligations which he has to meet. So the way we look at a problem can be different from the
whether we are physicians, whether we are other normal human beings, or from the viewpoint of the person who has it. So this is the gap we see. We have a person who is having certain illnesses or symptoms and who is interpreting his or her symptoms. And that's the reality. There's a human being there. But over the years, we look at these as diseases and a person who is having a disease. So much so that when we do ward rounds, and this is something which constantly has happened to me also because of years of brainwashing, I'm able to give the list of 30 or 40 patients from their condition. So bed 1 is ischemic heart disease with diabetes, probably having renal dysfunction. Second one is a pneumonia, might be even aspiration. Third one, patient is having tuberculosis. So we have basically filtered out certain non-biomedical aspects. We have filtered. And we have learned, or we have been brainwashed to look at diseases rather than the person. And this is something we have to, this is a challenge we have to meet if we are to go beyond the illness. So let's try to see how we can grapple with this issue. There are two concepts which we can use in this. One is the concept of medical gaze, which was first described by a French philosopher, Foucault, who described this in The Birth of the Clinic. The second concept is to look at it from the doctor-patient relationship and how we have learned to be doctor-centric rather than person-centric. So now let me describe a bit about the medical gaze. And as I mentioned, it was Michel Foucault who described this. And to read this, you will understand what I'm trying to say. So when you saw that patient, we framed that patient and interpreted that experience in our own disease label. We have labeled the person. We have not even considered the human being. And in the ward rounds, busy physicians know very well how this happens. And if you look at his argument, it's based on the history of dissections, how dissections made people identify diseases, abnormalities in organs, which have corresponding illnesses or diseases caused by certain pathobiology or pathophysiology, and how the origin of hospitals enabled people to be observed, patients to be observed, so that we begin to categorize patients. And how this has led to the way we are thinking. So the causes of diseases were found to be related to anatomy and pathophysiology. So it's not the patient whom we are worried about. We are now worried about the tumor or the inflammation or whatever is happening inside the organ. And the patient, the gaze towards the human being goes off, and we start looking at the pathology and the pathophysiology and the lumps and bumps. In this instance, we looked at the patient's seventh nerve lesion with the rash. And this made us move away from the patient's story. And we began to look at patients in a new way, in a way we understand them from our own perception. The second theme I want to discuss is how medical education also re-emphasize this process. There's a very influential report in 1910 in the US, which subsequently came to the to England, and then from there went to the colonies and have influenced the training of doctors in medical schools. And the one point they made was that we should have a structured way of medical education, a structured medical curriculum based on research. And that's one aspect of it. But the structure of the curriculum to be basic sciences followed by clinical sciences. See, previously it was more of an apprenticeship model where people would go and be with the teachers and learn on the job, while on the job. Even our Paramparika system has that, right? But here was a structured way of looking at medical education. So you have the history of development of medical knowledge, history of development of institutions, and the history of development of medical education. And in all these, we are looking at normal structure, abnormal structure, abnormal function, loss of function, and clinical features. And we start labeling the clinical features. So we're very differential diagnosis and tentative diagnosis is basically a label. We love that label. Not that it's useless, it is very useful, but it has its disadvantages too. So if you look at the curricula, they also reflect this. And interestingly, if you look at the departments in the faculties, we have basically replicated this. We have basically cloned what happened in Colombo, and Colombo cloned from what happened overseas. We had certain developments which happened, and everybody has followed. Previously, biochemistry was within physiology, it became a separate subject. Microbiology, parasitology was within pathology, it has come out of those subjects. Pediatrics and psychiatry was within Department of Medicine, and those have now become separate subjects. So there are one or two universities, I think KDU as well as Eastern University, which have made some adjustments, but the disciplines are the same. And it follows this basic structure, basic sciences and all these pathology and so on, followed by clinical sciences. So in other words, we have a very good system to brainwash people to have this medical gaze. So even within 5 years, we efficiently change their perception. Now, this system, there were responses against this. And we have discussed about Osler, and there have been discussions on on the way he responded to this. Even in the college, we have had lectures on this. And one response was to oppose this march towards the technical type of medicine. The second person was Francis Peabody, and he is considered to be one of the leaders in medical humanities. And then we have Pellegrino, who headed the Institute for Values and brought in this about compassion and the need to be humane. So these are all from the States. They have migrated from different places, but the impetus was mainly from the US. And medical humanities, which looks as the humanities in the intersection, arose initially in the US, and subsequently it came across the Atlantic to involve the UK also. And the use of arts and humanities in medical education has been as a wonderful publication by the American medical colleges. Sri Lanka is not far behind. We have had some major initiatives. One was the behavioral sciences stream, and that's where Prof. Nalaka Mendis was involved in that. I was also associated with him during the curriculum change, and which brought in ethics, communication skills, social aspects of medicine, and so on. But the real advancement in relation to humanities came in with the establishment of the department in 2016. And we held the first international conference on medical humanities in 2018. After that, COVID messed up a lot of things. And then now we have the Sri Lanka College of Internal Medicine. And I want to mention that, see, the initiative taken by the college, it's a pioneering thing. You know, even the Department of Medical Humanities establishing it was a pioneering step, because there are lots of people who have done medical humanities in the region. We have, experts like Satyendra Singh from India, Avinash Supe from Mumbai, Ravi Shankar, who is now in Malaysia. We have Madhusudan from Nepal, real pioneers. But they have found it very difficult to establish departments. The moment you establish a department, the rules of engagement in the system changes. Similarly, if you look at the Sri Lanka College of Internal Medicine, this is a pioneering effort, and I congratulate Ganaka as well as the team. And you have a fantastic opportunity to lead the pack, especially because we are all physicians, we are specialist physicians. And when, as specialist physicians, if we say, you know, being humane is important, that message gets across. So I think we must continue and improve on this initiative. Though we look at the West, if you really look at the East, we find that most of these are in our indigenous systems of Ayurveda, as well as in the Deshiya Chikitsa. And there's a lot to learn. There's a lot to learn from the way our Veda Mahatyas, how they look at people, how they look at, have a holistic approach. Some of the things we, in the Western medical field, used to laugh at about the diet has now been proven wrong, and everything is related to the microbiome, and then they are doing fecal transplants and so on. And certain concepts which we looked at in relation to medicine have changed. For example, now there is ecological psychiatry. Basically, you are saying that the environment has an important impact on the way you think. So we should tap into these because we have a rich heritage which we can tap into. Right. So, so far what I've dealt is, we started with an observation. I'm trying to explain this observation, how we have got brainwashed into this, and some of the responses. But now I want to move into an area, the doctor-patient relationship, in trying to go beyond the illness. And this is shown so well in this picture. We use this to show, to teach our medical students also on the connection between a doctor and a patient. In this instance, the child has died of a febrile illness, probably typhoid, and the helpless doctor is looking at this child, and the father is in the background. You don't see the mother next to the father. She's crying, and the father's hands are on her shoulder. And it's obviously a very poor family. If you They don't even have a bed. And this is from the industrial era in London, probably. And this is the doctor-patient relationship. One way of looking at this doctor-patient relationship, how strong it was, especially when biomedicine was not very powerful at the time. So if you look at this this spectrum of doctor-patient relationships, right? The common ones in the literature is doctor-centered, patient-centered, person-centered. I have brought in a new category called doctor-dominated, and I will show you why. This was published in the Ratnapura Clinical Society Journal, and why I say that is, this is a real story, right? Our patient, actually a retired teacher, went to see a consultant, and because she had forgotten, see the response, she had forgotten to bring her previous notes. And you can see the humiliation of a teacher, when a doctor who's the age, she might have taught that same age group. That's a humiliation, right? And you get this all over, especially in this part of the region. And this was published I was in India actually last week, 24th. Right? This went viral because a patient had asked some question because the doctor was getting late, and they decided to kick him out of the hospital. Subsequently, he was sacked. This doctor was sacked because there was evidence on the social media. So we have it's not just doctor-centered, we have a very dominant one. And this also, when we deny treatment during trade union action, it is a dominant position we are taking. We are doing that because we have power. We have absolute power. And so these are things we have to reflect on when we look at this doctor-patient relationship. So I'll give you 30 seconds to read the other commonly used definitions. So when we saw that patient, we labeled him doctor-centered. When we do a ward round, the house officer might say, this is Mr. So-and-so who's having such and such a illness, coming more towards the patient care. But if you look at it from a really holistic view, we look at the patient in a totally different way, right? He's a farmer, he has a wife is not well, children are having issues, and so on, right? So as physicians, how can we move from this doctor-centered to the patient-centered? Now, these are, I'm not in any way saying I am an expert, but I think these are the sort of things we should start to discuss so that we bring in certain guidelines for our juniors as well as to ourselves, right? So let's try to grapple with this. This is another case history. So you are at the NHS. This frail lady is brought with a referral note from the orthopedic clinic. History of fracture. And the carer has not brought the prescription. Now, what can you do? In a doctor-centered way, you may tell the carer, bring the prescription and come. You might say, this patient has come from the orthopedic clinic. Let's get them to do the test. Why should we be doing the test? Send them there. And if you need admission, we just say admit when and you start note. Right? So that's a doctor-centered. Now, if it becomes more patient-centered, you may want to ring home and find out what the prescription. Now you can WhatsApp anything, right? If you want to do the blood test, maybe you can do it in the medical clinic. Right? At least the random blood sugar. And if you want to admit, not only the carer, the family is at home, again, you might want to speak to them and say, "Mawa admit karanna ඕනේ අද මෙහෙම අසනීපයි හොම." Right? Some sort of discussion, and of course with the patient also. So that's a more doctor-centered view. Going from a doctor-centered view to a more patient-centered view. Now the problem we face is, what do we mean by person-centered in this situation? Because we have to go beyond the patient and we are going to look at the person, which means we have to understand and know what the patient, what we mean by person-centered care. And that is where we recognize the person as an individual. So in the first example also, we recognize the human being who developed the seventh nerve palsy and the Ramsay-Hunt syndrome. And we looked at some of the features which are important to that human being. And that's person-centered care. Now, if you can read that, I have underlined some of the key areas. So you will note that if we are to take this sort of information, practically, we are expanding on the personal and social aspects of the history and bringing in certain other aspects to the history, right? You see, if you have to transit from the usual history taking which we do, this is actually, we are getting more information in relation to the person, the individual, the human being who has got the illness. So you have identified cost of transport, lack of funds, no social support, difficulty in using the toilet, and wanting to use the indigenous forms of care. So if you want to be patient-centered and intervene, you have to look at other aspects, not only the medical aspects. And the new concept which is coming in is what we call social prescribing. This is like therapeutic diet. We can, there might be criticisms of it, but some of these labels help us to look at a problem in a different way. So in social prescribing, if we identify those 5 issues, we can think of prescribing or advising on certain things which will help the individual. So it's a prescription, you will see that these are simple things. And some of these we really do. We do this, especially when it is someone known to us who comes, later. Machang, what can we do for this? You will be going on social prescribing. We don't have time sometimes to do this with our patients. But if we start looking at this in a different way, maybe our students might give us clues. The junior staff might find clues on how to help the individual. So it's a mindset which we are trying to shift. So now that's So the first case first person I showed was the a person who had those lesions with the asymmetry of the face. The second person was about the clinic. But how can we, if you have to write guidelines or if you have to inform future generations, we'll have to have something more substantial. So this is why you have to dig into this and try to find what do we really mean. So if we really look at it, if you want to teach people, we can think of 3 areas. One relates to information gathering, so that's something like the history. Second one is decision making when it comes to investigation and treatment. And third one is mainly related to social prescribing and treatment. So I'm trying to build on our commonly used structure rather than think of a completely different structure. Because if I try to say, we have to completely change the way we are taking histories and so on, I don't think that's going to work, because it's far too premature to do that. It's much better to move towards this. And you will notice that some of the postgraduate exams overseas, how they have moved without these labels, they want you to think about these. And we have learned some of these aspects from exposure to those training as well as those assessments. So if you look at information gathering, you have to get the story, not just the history of differential diagnosis. You have to empathize, that is, you have to be able to get into that person's shoes. And you may have to ask a few direct questions, because PS people are also not very, they won't volunteer. So if you are looking at the story, these are a few things, right? Eye contact, smiling, invite the person to sit if the person is standing. When an elderly person comes, sometimes I stand up and greet them, right? Because that's our culture. When a clergy, we get up. If you see a clergy in the temple, you worship. When they come to hospital, you completely ignore them. No, you see a monk and you're a Buddhist, you do it in the temple, you do it in the hospital. That is a show, mark of respect. If you meet one of your old teachers, not me, I mean, if you see one of your school teachers, for example, and that's the way you greet by heaven's sake, do it, right? Because that's the biggest present you can give that teacher of yours who's now coming to the hospital to be under your care. So you have to build a rapport, and sometimes these non-medical questions help. If the person says he's from Tambuttagama, you just say, Janadipati te patten neda. Complete rapport. Then they'll tell, they'll start talking about Tambuttagama. So that rapport is important. If a person comes from overseas who has been in Kuwait, Kuwait with the Kali Hitler. Boom, right? So if you are really genuinely interested, the questions will come automatically. You haven't to be thinking of it. Silence is the key at the beginning. Once they sit, then kohomata mokadda amaharuwa and wait. Wait for 2 minutes max, because we don't have much time. Wait longer. But they just come out with their story, not the history, but the story. And then you may want to ask certain open-ended questions and carry out a two-way conversation. Empathy is where you are trying to understand and respond. A person who comes and says, Mage mahattya antara una, you have to understand, empathize, sympathize at that stage, right? And then try to, when you when you are empathizing and when you are in that person's shoes, then you realize their individual preferences. I mentioned about that person our individual preferences, why the person who has got Ramsay Hunt syndrome had to get sorted out quickly because he has to pay his loan and so on. And then direct questions. What are the direct questions? So what I did was, we have this home visits program, and Professor Sharif was the one who pioneered this. We send final year students, and I urge you, you can send your third year and at least the fourth year students just to make 1 or 2 visits uh, uh, to the homes of these people who are being discharged from hospital. This is different from community attachment, where people are there and they come to hospital. No, this is people who are in hospital, stroke patient, a frail elderly person, going home. And how do they manage? And the sort of points which were brought up by the students, I looked at those and came up with this. Some of the direct questions you might want to ask, because there can be such a wide range. I'm not saying that you have to ask all this, nor am I saying you have to have a tick box. But if at a stage Sri Lanka has social workers, they should be having this in their tick box list. So health issues, for example, we might forget to ask about the physical functioning. We might forget to ask about their caregivers. So it's a case of asking these patients about the aspects which we might not deal with often. So when it comes to personal and psychological, behaviors, certain behaviors, we usually ask these in the personal history. We capture most of these. But now, for example, domestic violence is something we might not capture, right? And access to healthy options in food might not be something which we ask. So when it comes to social issues, we look at, there are so many aspects which you can look at. Discrimination, safety, those are some of the issues which, again, we might not really ask. Language competence, and occupational hazards and so on. Right. So these are some of the points which we could ask our patients to identify the issues as an individual, as a human being. So first we get them to tell their story, and maybe a few things about empathy, and then maybe a few direct questions, just like our systematic review. Systems review, we ask certain questions, something like that. See, all these were brought up by students in their home visits. We've had it for almost 20 years, right? Sometimes garbage affecting, flies at home causing infections, diarrheal diseases, flooding, very common in Colombo, certain areas, and certain areas in Ratnapura, for example, how it affects health and so on. So first is you try to get the information. Then when it comes to making decisions in relation to investigations and treatment, shared goals, involvement of family and friends, and of course the patient. Now, how to practice person-centered care in the case of treatment? We have to now respond to some of their emotional and other needs. And this is where this idea of social prescribing can be used. Again, it's an interesting label, and it's being used now all over the world because it helps to formalize things and institutionalize the way you can respond. Now, I've given a list. Some of these we have done actually. Right? Arts and culture is coming in a big way now. Right? Because, in fact, last About 2 weeks ago, I was in a summit on urban health, and they had a whole workshop by an artist on using art and green space and so on to reduce stress and to improve well-being. Nature-based activities also is there. You see, we are often we hear people wanting to go to the gym. Gyms are there for countries which are too cold. Why on earth do you want to go into an air-conditioned room when there is such a lovely open space for you to walk? I just can't understand. It's such a beautiful, and you see, the psychology of exercising outside is different from exercising inside. And there is evidence now that those who live in high-rise apartments have different EEGs compared to people who are on the ground floor and exposed to green. And green space, there's a systematic reviews which have been done to show that living close to green space increases your life expectancy. So these have been worked out. And this fantasy of running to gyms, you can go to a gym and exercise, but do not compromise on your time to go out and take a gentle walk, not necessary to cut down your weight or anything, but for your mental health. So social prescribing helps you to capture these. And this is from a website in the UK, right, on social prescribing, right? So you can have a portfolio of social prescribing, which you can use, right? And we do this sometimes in community medicine in relation to people who have problems in their homes, but we have to bring this even into the hospitals. So that's up to now. I've spoken on the doctor-patient relationship, how we can respond, and how we can have a structured way of improving. But I want to discuss the role for the college, because I think that's something, again, just an outline, but I think that's something we have to do. And as I mentioned before, you're doing this is a pioneering initiative, right? This was just published a few days ago. What you are looking at is humane care and people-centered care. Actually, you can look at it as a new paradigm, right? So this was published just a few days ago. It's down. It's open access, and if you really want to cause a shift, you have to attack at different levels. You know, we can't just do it in medical schools. It will have an impact. Good if you can do it there, but if the college is interested in a paradigm shift, you have to understand it. Even if you can't do it, such a different question. But you understand that what you want is a paradigm shift. But because it's difficult, you are looking at something which is simpler, which you can do. So if you look at promoting humane care, you can look at humane healthcare workers. We are in charge of wards, humane wards. We work in hospitals and humane hospitals. We leave the ministry and the big people out. But at least this part, the college has fairly good control. For humane healthcare workers, education and training, and that's what you have been doing from 2022. And we can look at booklets, short courses, webinars, advocacy, and workshops. You can have short workshops where you identify the competency you want. So if you have that idea of a framework, then you know which competencies you want to target, right? Because you can't do everything in 2 hours, but you can do a part of it. So if you are thinking, for example, of compassion and empathy, there are well worked out methods, especially using literature, film clips, essays, storytelling, narratives, right? And we are doing most of these in the faculty, and the the medical schools in the region, they are leading the way in certain things like forum theater. That's where you actually have workshops and you have a theater experience for students. Very labor intensive, but these are also done. So again, there are educational theories which can be used for these, and I'm just giving you just to give a flavor of what can be done in the case of a workshop, right? But if you're thinking of humane wards, I mean, very simple thing, right? When you refer a patient, you refer to the cardiologist. What happens? The patient is put on a trolley and taken from the ward to the cardiology unit. Or cardiology refers and the patient is sent to you in a trolley or in a wheelchair. That is doctor dominated, right? If there's a referral, we should be going there. There's a referral. See the time, the discomfort. Remember when they're going on a trolley, no shock absorbers, right? And we send them, you would have seen them, daga, 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 and they're going on a trolley. Sometimes the distance is quarter mile. Okay. So there are simple things. Now we don't have in the system, we don't have multidisciplinary teams, except in oncology they have, in some of the chronic disorders they have, in renal transplants they have. So which means it can be done. So if you have a special interest, should you try once a month even, one-stop shop, a multidisciplinary team from the different disciplines. At least in the private sector, we should be able to do it at a higher cost maybe for the patient, but the patient will prefer it because he's not paying for 5 visits. He's coming for 1 visit. So this gives certain things, patient information leaflets, right? Then improving the environment, nature, art, spiritual recreation, which, we wanted to hang some pictures in the wards and the matron said, no, pictures cannot be hanged in the hospital. Archaic, right? Because what do patients do? You're on a bed. For example, even in the ICU, right? If you're on a bed, the only music you hear is the beeps of the ICU machines. And you're there lying down, looking at a white roof, 24/7. Should we be giving them music? Right? So promoting humane hospitals, again, there are things which we can do. And if you look around, actually our staff, our minor staff, what we call minor, not minor, actually junior workers, they are really into this. You would see them organizing gardens, and without our encouragement, unfortunately, we should be encouraging, but the sort of things which can be done. I want to highlight this because this is by completely on donations. They built this cancer care center. And the architect was Mr. Anzulendran, who can see his picture there, right? And that's a palliative care unit. Now compare this with what we have as hospitals. And this is not extravagant costs, I'm telling you, not extravagant costs, very cheap. And look at that. Right? You think a child or a young person wouldn't like this, or even an old person? You see, because if you're not doing anything and you can't move much, there's something which you can go on looking at. Okay. So, in summary, what I've tried to do is to first to show you an observation, try to explain it using medical gaze and the development of film. The responses initially by the experts in the previous year, some of the institutions, and then focused on the doctor-patient relationship. And there I've focused mainly on how we can shift the doctor-patient relationship from a doctor-centered to a more person-centered. Doctor-dominated should be something we have to get rid of. That is not, it is not there in the literature, only in our literature, right? So we should be moving more towards the person-centered care. And in person-centered care, I've tried to bring in a few practical aspects which we can do, because often we are theoretical and we are not able to practice it. So that's something which the committee can take on, even discuss how we can really practice this. And then come into humane wards, consider humane wards and educational programs. And that's the final summary. Thank you very much.
Thank you very much, sir, for that insightful lecture, empowering the listeners to practice humane and person-centered care. So I believe the audience have questions for discussion. So we would like to take up a couple of questions. From the virtual participants, they can submit their questions if they have any to the chat. And physical participants, they can forward the questions here.
Very much, sir, for that very illuminating and enlightening lecture. Just a thought that came to my mind. I think in this day and age, we talk about precision medicine. There's quite a bit of emphasis on precision medicine, but I think it's more centered on the genetic profile or the biochemical profile of the patient. So can we introduce this concept of the human aspects of the patient into precision medicine? That we can promote that.
Yeah, sure. I mean, I quite agree. The problem is that is dominated by the biomedical model of genes. That is the only problem. But this is also, you are trying to be more precise, but precise in relation to the human being, not the disease entity.
Thank you.
I was, I was telling Ganaka also, there is a huge opportunity for the college to, Krishant also, I was mentioning this, for the college to lead this in the region. In the CRO, there is a lot of interest on improving quality through either humaneness or compassion or person-centered or whatever. They haven't still figured out how to. But this is a particular area which the college has great potential. And you see, so if I think the way forwards would be to discuss further how you all want to move forward to what sort of things you want to implement, budget it, and then see what can be done.
We have a question. Yes, sure. We have a question from the virtual participant. Dr. Shehan Silva is asking, so how do you draw the line between giving your personal space by WhatsApp, mobile phone, sharing for communication and other issues, such as medical legal issues, formal communication, personal time, not compromising family time, etc.?
That's a very good question, Shehan. There's no hard and fast, I mean, there's no clear-cut answer. I think it's a value judgment you have to make. In certain instances, we have to rely on WhatsApp and mobile phone. Perhaps we should, if this is accepted, you could have, official telephones, mobiles. And the provision could be that the conversation is recorded, so that if there is any medical legal issue, it can be overcome. In this day and age, I think we'll have to think of innovations which quite, I mean, your point is well taken, which will help us to navigate this new area. Now, there's a guideline issued by the SLMC on social media. I don't know whether they've discussed about use of WhatsApp and so on, but perhaps the SLMC should be giving us more guidelines on that. Yeah, thank you for that question.
Can I add something for this?
I believe we have two types of relationship with patients. One thing is formal, and you become equal partners of a legal contract, where this type of cases can be seen. But on the other hand, if you have a more humane type, more personal type of relationships, would you encounter this type of a legal battle with a patient?
Yeah, again, you see, it's very how much when we are dealing with a patient, I think it's important that we deal with the emotional needs. But then, of course, it will depend on what sort of emotional needs. So emotional needs in relation to the patient's illness. Because there was a time when we were told, leave aside your emotions when it comes to patients. Don't tackle their emotions. You are there to look at that body and, treat the pathology. But now we have shifted from that. So if the person is crying, we are supposed to respond to that. So again, it will depend that demarcation it has to be made. Now, the issue in Sri Lanka is we have, after some time, you have patients who become very friendly with you. And of course, you have friends and your relatives who become your patients. That's very difficult. Depending on the issue, that can be difficult. How much you're going to interact and what are your demarcations. No hard and fast rule. In some countries, they avoid that by saying, do not take part in the treatment or therapy in relation to people who are very close to you. So one way out is where even if a person wants you to be under your care, where you get another colleague also involved, right? Or you gently say, I know of certain doctors who have set up a rule saying, I will not be treating my relatives and so on. So these are personal choices, Ganaka. There are no hard and fast rules. And I think, again, as the committee, we'll have to bring up these so that people reflect and consciously come up with what they want to do. Yeah, thank you.
Thank you very much, sir. So we are truly grateful for your commitment to humane care in the field of medicine in Sri Lanka. So with honor, we would like to invite Dr. Krishantha Jayasinghe, the President, Sri Lanka College of Internal Medicine, and Dr. Ganaka Senaratne, Chair, Humane Care Expert Committee, to hand over a token of appreciation on behalf of the Sri Lanka College of Internal Medicine to Professor Saroj Jayasinghe. Thank you very much.